Okay, good afternoon, everyone. Thank you for staying around for what will be our final panel of the day. This panel is going to be looking at the acquisition of the Detroit Medical Center by Vanguard issues related to the corporatization of healthcare governance, its effects on Detroit, its effects on southeastern Michigan, and the future of healthcare in this community. And we have a really great panel today. I'm going to briefly introduce the panel and get right to it so we have plenty of time for the remarks of the panelists and some questions at the end. Our first speaker is going to be Marjorie Mitchell. She is the president of the Michigan Universal Healthcare Access Network. Second speaker following her will be Peter Jacobson. He is a professor of health law and policy in the Department of Health Management and Policy at the University of Michigan School of Public Health and the director of the Center for Law, Ethics, and Health. Third, we'll have Dr. Herman Gray, who is the president of Children's Hospital of Michigan. And finally, Dr. Robert Frank, who is a professor and former dean at the Wayne State School of Medicine. So without further ado, let me have Marjorie Mitchell come up to the podium.
Thank you. Good late afternoon. I'm here today representing a group that we called the Coalition to Protect Detroit Healthcare. And that group consisted of MichUCAN, our organization, an education and advocacy organization on healthcare issues since 1990 here in Michigan. The Michigan Legal Services, Gary Benjamin is on our board and was very, very helpful in helping us to analyze a lot of the precedents, the legal precedents, and helping us to write our letters, etc. Moses, which is an interfaith advocacy group here in the Detroit area. And so we came together to form this whenever it was announced that DMC was contemplating selling to Vanguard, a for-profit out of Tennessee and owned by Blackstone. So what happened is that this is not the first time our organization in Michigan Legal Services had been involved in the attempts to convert a hospital from a not-for-profit to a for-profit. Back in 1997, Columbia HCA was contemplating a merger with the Michigan affiliated, it was the Ingham County health system in the Lansing area, Michigan Capital Healthcare. And the community came to us and asked for our advocacy with them to try to stop the merger. So we became involved at that time. And at that time, Attorney General Frank Kelly was very, very interested in also stopping the merger, and he took the leadership in filing a lawsuit, contending that the Michigan nonprofit corporation statute would prohibit that kind of a merger, and he was successful in making that case. In Judge Giddings' opinion, he clearly said that he felt that no assets he said, in our view, we cannot permit nonprofit assets to be used, conveyed, or distributed for non-charitable purposes. And he was upheld by Judge Giddings in that lawsuit. He further said that the mission of a nonprofit is to serve community, and the mission of a for-profit is to its stockholders, and that those two things, whenever you were working, there were community assets within the not-for-profit that the community had supported over the years, that you could not use those accumulated assets, community assets, and convert them to a for-profit. So we talked to them afterwards. The merger did not go through because the only way that they said that it could go through is if that they analyzed what the dollar value of those accumulated assets were, and that those assets were then put into a community foundation that then the community could use to supplant whatever healthcare services may be missing when the for-profit merger came over to expand services or whatever. It turned out that the size of that foundation and the amount of the community assets in that merger were too big, and Columbia ACA backed away from the merger, and we thought it went away. We then talked to Attorney General Kelly and then Attorney General Granholm, because it kind of bridged those two attorney generals, and contemplated legislation at that time that would, absolutely once and for all make it not possible in Michigan for not-for-profit hospital systems to be sold to for-profits. We were dissuaded at that time by Attorney General, primarily Granholm at that time, saying, we have there will never be a merger or a sale of a not-for-profit hospital to a for-profit in Michigan, because we have all the tools that are necessary in our nonprofit corporation statute to be able to stop all of them. We believed them and we backed away. Then in 2010, when DMC announced its intention to be purchased by Vanguard, who is owned by Blackstone, as I said, a hedge fund, we were very, very surprised, because we really thought that the issue was pretty well dead, because the attorney generals had been so strong that nothing more would come of that. We had a number of concerns when the announcement came. Our first concern was that the announcement was such a surprise, that DMC has been a community asset for many, many years, and that the community had not been come to and talked to about, were there any other alternatives, what could we do to save DMC, and alike. It really came out in the newspaper one morning, and my knowledge was that everybody was as surprised as we were. So that was one of our concerns. Our second concern, of course, was the legality after our discussions and our experience with Columbia ACA. A third concern was that we have a tradition in Michigan of nonprofit hospitals, and we saw that it would be eroded if this sale were allowed to go through. Concurrently to this time of DMC's announcement, all of our organizations were involved heavily in working at the federal level to bring about healthcare reform to this country. We understood clearly that our current healthcare system is fiscally not sustainable over time, that it costs too much, that we're covering too few, and that we just have a lot of problems. For all the money we spend in America, our health outcomes are pretty deplorable. And so one of the mantras of all of us in working for healthcare reform was more healthcare dollars for healthcare and not for administration profits and marketing and all of that sort of thing. So we were really pushing to get more healthcare dollars directly to the people and to give consumers more value for their healthcare dollar. So it was very distressing to us when the reality that Michigan healthcare dollars would be going to Tennessee and then to Wall Street. It was pretty distressing for a number of us. Research from health economists, and the last concern had been indicating that for-profit hospitals were often quicker to cut needed but unprofitable health services in order to meet their profit goals, negatively affecting access to these services in their community. The fact is, there are a number of health economists who would contend that healthcare is not a market in the usual sense, and that there are some things that should perhaps never be privatized or be made for profit, healthcare perhaps being one of those. I want you to know that DMC and I had prepared well for this sale prior to making the public announcement. They launched immediately a broad and very intense marketing effort to help sell the community on the sale and what the benefits to the community would bring. But the thing that was really, for us, the most difficult for us was that they secured a statement from former Attorney General Frank Kelly's law firm that the sale was legal. And primarily in his statement, the differences between the Columbia HCA and the DMC efforts to become for-profit were clear to him. He felt that there was no community assets, that the debt of DMC was so high that there really were no community assets to ascertain and to be transferred back to the community. And on page 5 of the original lawsuit that he had filed as Attorney General, Judge Giddings had said that if there were no community assets, or if you transferred community assets, that you could sell all of your buildings and things to a for-profit. And that took us very, very much by surprise. We came together, however, and wrote to then Attorney General Mike Cox to express all of our concerns. One, we wanted to be assured that the interpretation by Frank Kelly and his law firm was indeed accurate, a good interpretation of Judge Giddings' decision. And we also wanted to raise a number of other issues on behalf of the community. We had requested a health impact study. And a health impact study would look and say, what will the impact, and especially on the uninsured in the Detroit area, what is the impact of this sale going to be, so that the community could weigh that as they looked and decided how they felt about it, and so that DMC could know any degree of concern in the community of what was going to happen to charity care. And then we asked, what are the essential services that you run? And if essential services presently provided by DMC will not be continued, how will Vanguard see that the community has these services available to them? We asked that, again, that they evaluate the assets of DMC to see whether or not this legality was going to stand. And if there was a net asset to the community that needed to be transferred back to the community, how would that be done in the form of a nonprofit corporation? We asked how the community could be assured of the enforcement of the agreement between Vanguard and DMC over time, to make sure that in the agreement they agreed to 10 years of charity care and a number of other things. How were we going to be assured of that? How was it going to be monitored over time? And whether or not the amount of charity care would remain the same in perpetuity, that as long as there was a need for charity care, would DMC be helping to provide that in this community along with other hospitals? We also expressed in that letter a concern for the financial status of Vanguard, because there were a number of articles in business magazines at that time about the cash flow problem that Vanguard was experiencing, and we had a real concern that if that continued, would Blackstone sell them, and then where did that leave everything else as it went? And DMC had worked out something that that they would come out financially ahead if that did occur. We raised some questions about the Renaissance zone, and because that was a tax exemption, how is that different from other tax exemptions? And would that not still make them be functioning as a not-for-profit even though they were a for-profit? And meant wanting to make sure that the Renaissance zone could only be used for health care. And so we raised the questions of, could Vanguard in that Renaissance zone do anything else for profit within that zone? So we raised a number of questions and spent a good deal of time, a number of months. We met with the Attorney General's staff 2 or 3 times, had phone call communications a lot. DMC offered public forums on the merger, and we gave testimony at those. We gave testimony to the Attorney General, and we also gave testimony at City Council on the Renaissance Zone. Now, the sale of the DMC ultimately went through, and some of our concerns, were addressed. We were able, within the final agreement as it got modified, there is an agreement that they would set up an oversight board called the Legacy Board, which would function through the end of the contract, and that it would be independent of DMC, and that it would assure that everything in the agreements were carried out. And indeed, that board has been set up. We are meeting with them quarterly at this point in time. And, they have a hotline now that is pretty much operational. It hasn't been well advertised at this point, and at our last meeting, we spent a lot of time talking about that and how we as advocacy organizations might be helpful in seeing that people knew about that hotline if there were concerns on care or how people were treated. and we're still kind of working our way through that issue. We do share with the Legacy Board not so much our concerns about numbers of people who go through for charity care and that sort of thing, but we deal a lot with quality and are trying to work through with them how they can also address not just the numbers of charity care, the amount of dollars that they're spending and that sort of thing, but what do people think of their care? How are they responding to it? And is it of a high quality? And we have shared vignettes of people who have come to us with certain kinds of issues. We had in the beginning an issue relative to some Coumadin services that DMC ran, and those were being transferred to free clinics who did not have the capacity to accept them. And so, you know, we've been working through that issue. We have had people with no insurance who have been told never to come back to the emergency room, to go to one of the other hospitals in the area. And we talked about education of staff and treating of people who have no insurance and who need to use that service. So we work through these things and try to come up with solve the problems, not from a you're bad, we're good kind of thing, but how can we make this better? How can we do something that is in the benefit of the city of Detroit and its people? So it will be an ongoing process, and you know, we do not know yet. You know, it's going to take time to know whether or not it is going to function. You know, whether the quality is going to be retained and all of that, but we will have to see. The primary concern again is trying to get as many health care dollars to people as we can, and to try to limit the amounts of profits that we have in the healthcare system. And this is something that communities all over the country are talking about. How do we see that we do not spend our healthcare dollars? You know, we partially solved it through the Affordable Care Act with insurance companies by limiting the amount of administrative and profit that they could take out of the healthcare dollar. We're able to do it, but you know, it hasn't trickled down yet to providers and hospitals and that sort of thing. But we're going to have to confront it because we have a healthcare system that if we want it to be there to give us what we need when we need it, it's going to have to be affordable. And in order to be affordable, we need to make sure that our dollars are spent wisely and that we all get value for our dollar. So that is, from our perspective, from the consumer's perspective, what our concerns are, what we're trying to do to be DMC, to be the best it can be, especially in the charity care arena. And we'll keep working with the Legacy Board to make that happen. Thank you.
Computer types here. Sorry, I have a thumb drive and I can't. Anyway, I appreciate.
If I'm your IT help, we're both.
We are in trouble. Well, there's more to come that involves you. So, hi, it's a pleasure to be here today. Marjorie anticipated several of the points I want to make. Perfect. Thank you. And I want to talk about broader trends that are helping to shape the kinds of issues that Marjorie and my other colleagues will be talking about. And I have sort of two bottom line conclusions to note. And the first is that all of the pressures are toward a market model, toward a for-profit model. And we have to recognize that. I'm not talking about the validity or the desirability of the Vanguard DMC transaction per se. Rather, I want to set it in this broader context of what's driving these kinds of transactions. And the second, sadly, is there's nothing new. This isn't a new issue or a new problem, as we'll get to. So, I do want to state that my thinking over the years has been very much influenced by Professor Peter Hammer's work, and I am always appreciative of his thinking in this area and find it really very insightful. But don't blame him for anything that I have to say. So some organizing principles in thinking about this are that rapid change from now on is going to be the norm. I don't see any slowdown in the changing constituency in healthcare, the changing organization, the political battles over it. The Affordable Care Act is just the beginning of what we're going to see over time. Second, change isn't dependent on the Affordable Care Act. Most of what I think is happening is occurring independently of the Affordable Care Act. To be sure, the Act stimulates a lot of change, and there's a lot it will continue to stimulate a lot of change. It will stimulate, assuming it survives constitutional challenge and or a Republican appeal in the next repeal in the next administration. Third point is that these trends, in my view, represent a fairly unstable mix of consolidation, fragmentation, and segmentation. While these trends represent opportunities, they obviously represent real problems. If we assume, as I think we can, that there's a greater trend toward consolidation and the emergence of larger systems, it means that smaller players are vulnerable. And that goes to both smaller physicians groups and smaller hospitals that don't have the economic base. In particular, it means that facilities serving a low-income population are especially vulnerable. And that's the DMC story that Marjorie tells, and all of the problems and the issues of what do we do with it. So what are the key drivers? And this gets to my point about where the pressures lie. It's an increasingly competitive, a fiercely competitive environment for market share, for margins. There's a decreasing public willingness to support the safety net, to support facilities that provide care to low-income patients and communities. And so the Vanguard transaction represents a response to these drivers, in my view. Marjorie is quite right. The trends in costs and benefits and community benefits are unsustainable, but they're unsustainable in part because we're seeing disruptive technologies that essentially are driving this. And if there's time, I'll come back to what I mean by this. And changes in reimbursement. If anything, the pressures over time are going to be greater with reduced reimbursement in the Medicare and Medicaid markets. Well, here's to my second point, the history. Or we've seen this movie before. When I started in my career in healthcare, which was not the beginning of my career, sort of a ways into my career, I was at the Office for Civil Rights in the Department of Health and Human Services, then Health Education and Welfare, in the late 70s, when we were dealing with hospital closures and relocations at that time as market conditions changed. And particularly, we were concerned about economically distressed facilities, and that which led to the major hospital closure battle in New York City under then Mayor Koch, who wanted to close several of the New York City Health and Hospitals Corporation facilities, and indeed was successful in closing 2 or 3 and transforming another 2 of the facilities into clinics. We were also dealing at that time with the charity healthcare system in Louisiana, which was probably the most robust charity system in the country, perhaps with the exception of California, although even by then the California system was under attack. And in Louisiana, you had sort of a two-part problem. One, you had hospitals closing within the inner city, particularly in New Orleans, but also you had hospitals relocating into the suburbs, the wealthier suburbs, that could afford to sustain the care. But again, it's not new. And then into the early 2000s, The Meath case in New York was the Manhattan Eye, Ear, and Throat Hospital, which was under siege because its market had changed. Not dissimilar in some ways to the story Marjorie told. The market collapsed from within, and without going into all the details, it's a case about failed governance. I'm not knowledgeable enough to talk about the DMC situation, but the Meath case was failed governance, where the Board of Governors said, let's monetize the assets and sell it off to the highest bidder. In that sense, it's not dissimilar to the DMC situation. The difference is the State Attorney General challenged the transaction. All right, so what are some of the current trends also that we have to contend with? One, forming accountable care organizations. As I suggested, smaller players, independent players, are going to have a hard time competing in this environment. You've got to align with physicians. No alignment, no accountable care organization. It's all about market share. Building a new culture, developing new performance measures. But there's considerable uncertainty surrounding health reform, the future of hospitals. Well, do we think that what we view as hospitals now will look the same in 2025 or 2030? I'm not sure. In fact, I don't think they will. What I'm going to argue is that essentially, I'm going to skip this for time, that you're going to face basically a different world in 15 years where hospitals will be to help navigate health, broader health of the community, and provide really only care for the very sick patients. What happens to safety net providers in this? Well, we're seeing it. Conversion of nonprofit to for-profit, potential closure, mergers and acquisitions, and a transition to a different status, perhaps clinics. Why? The need for capital to compete. States and localities are not willing to supply the capital to meet the community benefit. Second point, these facilities are under great pressure from Congress to meet the community benefit obligations. How are you going to meet it going forward? And I think here the obvious answer is keeping the population healthy. How you do that is going to be the challenge for healthcare administrators. All of this is compounded by payment reforms, cuts in Medicare and Medicaid reimbursement, even in benefits, even if the Affordable Care Act is implemented, you're going to have this massive number of previously uninsured patients now presenting at places like Vanguard DMC. Is the Medicaid reimbursement rate, which is likely to decline, going to be adequate? If not, where do they get the capital to survive? There's going to be renewed emphasis on outcomes, penalties for readmission, rewards for quality improvements, what you were essentially talking about. How do you handle this in a move toward bundled and episodic care reimbursement? It's going to be a challenge. Let's skip that. A broader question moving forward for us to think about is whether the nonprofit form is obsolete. Marjorie is absolutely correct in the two of the points she made. There's operational convergence. It's very difficult to tell a nonprofit from a for-profit in terms of the day-to-day operation. The governance systems are the same. The pressures for generating revenue are the same. That's why the ACO, to generate revenue, to align physicians and the health systems. But the big difference that my colleague Jill Horowitz's research shows very clearly is that for-profits are simply unwilling to sustain money-losing services regardless of the community need, regardless of the community benefit. That is, as you point out, the big difference. Going forward, you need nonprofits to push toward a population-based approach. One could argue the broader mission will never change, and therefore it's desirable to maintain a nonprofit form. If what we're really concerned about is keeping people healthy, can for-profits do it better? I may be dubious, but I think it's an empirical question and it's somewhat open at this point. Vanguard brings capital to be able to develop wellness prevention programs that a fiscally stressed facility in a low-income area may not be able to do. So there may be some advantages, and we're beginning to ask, how do we keep the community healthy? And I think that's an essential question for Detroit and other low-income communities to be grappling with, regardless of the organizational structure. So to your point, which I think is really the critical one, how do you enforce the agreements that were made? And how do we extend those agreements so that the focus is on getting the community healthy, so that we reduce the pressure on emergency departments and the system generally? If this is correct, I think we're going to see a very different role for health systems and hospitals going forward. We're going to be shifting care to the least costly, highest value venue. That could be home, it could be neighborhood clinics, where the hospital may be a care navigator, working with community organizations, working with patients as advisory board members to ensure that the patients get the kind of care that the hospital works with employers, and let's say the Detroit Wayne Health Authority, to develop prevention and wellness systems that actually work and keep people healthy. I think a lot of this will be served through disruptive technologies, social media. If we can get it to the people in the community, if we can get telemedicine, if I can open my iPad and talk to my physician in a way that he or she can then give decent advice or tell me, you've got to come in, I'm not sure. We can start to use the social media technology in terms of both changing the organizational role and to go where the patient is, to deal with the difficulties of getting patients in so they put off their care. So I think the disruptive technologies are an interesting way of thinking about this problem. And I think we have to integrate population health into the clinical encounter. When we focus on community health, we use the community health needs assessment process to really identify what the community needs and force the systems, whether it's Vanguard DMC, Henry Ford, University of Michigan, Beaumont, or Spectrum on the other end of the state. It doesn't matter. How do we use the processes that are now available to identify community needs and meet them? And I think my time is about up, so I'll stop there and just say finally, where will safety net facilities be in 20 years? I don't know. It doesn't look like there's a single-payer system anytime soon. I think it's the trend, the pressures are all toward a market-based good, and probably we'll do what we always do, which is muddle through. Thanks.
Good afternoon. It's a pleasure to be here this afternoon and to participate in today's program and with this important agenda and certainly with this panel, the distinguished guest, provocative and very interesting comments made by the two who preceded me, and hopefully we'll get to talk a little bit about some of the things that both Margaret and Professor Jacobson brought up. And I would thank the organizers of this event, the Journal of Law and Society, for convening this really very interesting and important public forum. You know, I'm privileged to serve as the president of Children's Hospital of Michigan and a senior vice president at the Detroit Medical Center. I've been the president there for almost 7 years, and before that, chief operating officer for a couple years. And I appreciate Dr. Jacobson, Professor Jacobson, pointing out why I have insomnia and the things that keep us awake at night. You hit a lot of them right, nail right on the head. Children's, as you may know, this really isn't going to be a commercial, but I think it is relevant, is a nationally recognized children's hospital. We sometimes forget that we have a national jewel right here in our community. And it serves children not only from Detroit and southeast Michigan, but every year we see kids from virtually every county in the state of Michigan, the surrounding states, and several countries, depending on what specialty needs they may have. I've been asked to address the position that the for-profit avenue is or was the only viable option for the struggling DMC, as well as to discuss the DMC's commitment to the indigent and whether it will continue. It's an interesting position. I find myself as a pediatrician who was raised in the late 60s and 70s, I remember seeing pictures of Dr. Frank, who will follow me as a radical-looking hippie kind of guy. And while I may not have been quite as radical-looking, I think you had more hair than me, Bob. I never sort of envisioned a day when I would be standing at a forum discussing and perhaps even justifying why the hospital that I love dearly and lived my entire professional life in is a for-profit hospital. But it is, and for the next 10 to 12 minutes, I will give a brief recap on where the DMC and Detroit's hospital environment were prior to the Vanguard Health System acquisition, two, quickly summarize some of the major components of that deal, and thirdly, address what's happening now. A little over a year after the deal was closed on January 1, 2011, my perspective, of course, is that of a system leader and a hospital president who's actually responsible for the daily operations and strategic direction of this children's hospital. And I meet with new employees every month. I met with them yesterday, about 30 new employees, and every employee in our place is told that, and every physician, that we provide, our mission, our goal, our existence is to provide great care to every child who steps through our front doors in as excellent a manner as possible every single day to every single child, be it a 15-year-old mommy with her first baby by herself or the chairman of the board's grandchildren. Prior to the Vanguard deal, DMC, of course, was a private, nonprofit healthcare delivery system. It served as the virtual healthcare safety net for Southeast Michigan and the city of Detroit for decades, even as other health systems left the city and relocated in suburban locations. In 1987, there were 19 safety net hospitals in the city of Detroit, including 4 DMC hospitals. By 2009, there were 6 safety net hospitals in the city of Detroit, including the same 4 DMC hospitals. All of the hospitals that left Detroit were, of course, nonprofit hospitals. And interestingly, most of them were also religious organization hospitals. This safety net responsibility and the commitment that came along with it came at a great cost to the DMC, with our most severe financial crisis coming in 2003 when the system lost about $107 million. It was also significantly indebted, roughly $450 to $500 million in bonds that had accumulated over many years. Following Mike Duggan's appointment as CEO in 2003, the following years the system steadily increased its bottom line performance into the black consistently, and we thought we were heading in the right direction. And before the national and worldwide financial crisis in 2008, the DMC was poised, indeed the documents were prepared, and the schedules were being set up to go to Wall Street and the bond market to obtain capital to strategically improve our facilities and strengthen our financial position. That never happened. The change in the ability to borrow money basically destroyed those opportunities. As you know, at that time, even those organizations with impeccable credit could not borrow. And in the hospital business, if you can't stay current, You talked about disruptive technology, but for us, any technology, certainly in the hospital business, has been experiencing exponential growth. And if you can't keep up with that growth and cutting-edge treatments, you die. You go out of business. It's just the end of your story. And that was our situation, fundamentally. When the deal with Vanguard was closed, there were a number of features in the contract that I think are relevant for our conversation today, and that I point out, and always be leery of a general pediatrician discussing contracts in a law school setting. It strikes me as terribly hilarious. But be that as it may, my daughter, who's a young attorney, would think this was horrific. But continuing on, the contract obliges Vanguard Health Systems, the owner of the DMC, to continue operating all the DMC hospitals for a minimum of 10 years. They are obliged to provide charity care under the DMC historical policies for a minimum of 10 years. It's interesting to note that that was the initial obligation, but it evolved prior to the deal closing, and a decision was made to adopt the Vanguard Health Systems charity care, financial assistance, and billing and collecting policies for uninsured patients, rather than the DMC's charitable policies, because the Vanguard policy actually was a more benevolent policy and a more generous policy, providing the opportunity for higher income levels to qualify for financial assistance under federal poverty guidelines. The contract also obliged Vanguard Health Systems to fully support the DMC's educational mission and to honor all educational contracts, including those with Wayne State University and Michigan State University. It obliged Vanguard to support the DMC's research mission, including its commitments to the Carmanos Cancer Institute. It obliged the Vanguard Health System to operate the DMC as a Detroit-based system and to maintain the regional headquarters in the city of Detroit. And of course, there was cash. There was $850 million in capital for new facility projects committed, and $350 million in operating capital expenses for the hospitals over a 5-year time period. As the historically, for a long, long time, the most profitable, as it were, hospital in the medical center of Children's was embarked on the silent phase of a capital campaign to build a new patient tower prior to us also being surprised and learning about the deal. It was pretty clear that while we were doing a pretty doggone good job at raising money, it was going to be a long time before we raised enough money to build a $200 to $250 million patient tower. So, the other thing that occurred with this deal, of course, and it was alluded to with our first speaker, 2 foundations were created for the charitable assets that could not be purchased or assigned to Vanguard. Children's, as an example, had some $90 million in philanthropic donations sitting in its coffers. Those were transferred to the Children's Hospital of Michigan Foundation with the Attorney General's approval this past summer. And just recently, the Health and Wellness Foundation, the adult foundation, which has $40 to $50 million in it, was also approved to have those dollars transferred to it by the Attorney General. Most of us who work at the DMC are proud of our legacy of serving anyone who walks through our doors, and we wanted assurances ourselves, as did our political leaders, that there was a real and fundamental commitment to serving the uninsured and the underinsured in this new world we were entering. We got that commitment contractually. There are very sizable penalties in the contract if those commitments are not kept. There's a warrant for some $500 million if Vanguard substantively violates the terms of the contract. So now, more than a year later, what's happening? Literally today, there was a groundbreaking for a new emergency department and intensive care unit and other facility enhancements at Sinai Grace Hospital in Northwest Detroit. Sitting in my office, as I look out of my window at Children's, I see the finishing touches going on a new 105,000 square foot specialty center, ambulatory specialty center, to open in a few months. A new DMC heart hospital has begun construction next door to Children's. Children's is opening a new site in Canton in June, and as you've probably seen in the news recently, we're working with the city of Royal Oak to open a new site there within the next couple years. We have maintained our historic commitment to the underserved in our hospitals with virtually the same level of charitable care given now as before the deal, at least if you can measure it in dollars and cents. And it was mentioned, they're concerned perhaps about quality. If anything, the quality of the hospitals, I think, has improved since the deal. More hospitals have been recognized by things like U.S. News and World Report than prior to the deal. The focus of the organization has, like most hospitals now, is relentlessly going towards quality and high reliability organizations. That is not just a moral and a business, a moral imperative and an ethical imperative, but it's also good business. You provide lousy care, people vote with their feet. They can go someplace else. And so there's a great deal of pressure and focus now on quality in our organizations. It was mentioned the Legacy Board that was created by the Attorney General to oversee the deal and assure that these commitments are being honored. And they receive quarterly reports on our performance. And in the most recent report to the Legacy Board dated February 28th of this year, the DMC reported that all of its hospitals, of course, continue to operate as licensed hospitals. That would have made news if they weren't. And that the core services defined in the contract that were being provided prior to the deal continue to be provided, and an assurance of there being no intention to discontinue any of those core services. The DMC provides detailed information, including at that February 28th report, to the Legacy Board as required on the level of financial support to charitable care, and verified that the level of charity care in 2011 was virtually the same as in 2010. It was further reported that the DMC Vanguard commitment to the educational mission was strong. In 2011, the DMC trained more medical and osteopathic residents than in any other year in the DMC's history. We maintain our commitment to train medical students and allied health students at the same levels. And in addition to medical education, the DMC trained roughly 250 more nursing students from more than 35 nursing schools in 2011 than the roughly 5,000 nursing students that were trained in 2010. We believe that we are serving the community at least as well as we were prior to, and in many respects better than the Vanguard deal occurred, after the Vanguard deal occurred. In conclusion, I would make the observation that the DMC's commitment to the city of Detroit and to serving those less fortunate is real, is concrete, is greater than that of any of its competitors still, and is ongoing. Additionally, now as a for-profit, outside of that renaissance zone for the next, now 9 years, we're paying taxes in a number of our locations. We pay taxes out at Sinai Grace in Northwest Detroit. We're paying taxes in all the locations that Children's has in West Bloomfield and Birmingham and soon to be Canton and Southfield. We have a number of locations now. And so we're paying taxes, and so communities are benefiting in several ways from the DMC Vanguard deal. The data on the behavior of nonprofits compared to for-profits is difficult to interpret. It stretches over a long period of time. Certainly, I would never have been proud to be a member of Columbia HCA, I think maybe 15, 20 years ago. Columbia HCA then certainly doesn't look like Vanguard. It looks like today, at least. But I think it's a fair statement, as we pointed out, that time will tell whether this really was a good thing for our community or not. But it is difficult to tell the behavior of a non-for-profit from a for-profit and looking at what they do. To me, I believe this is in part because, like human beings, companies are different, and their behaviors may differ significantly. All nonprofit hospitals are not alike, nor are all for-profit investor-owned hospitals alike. Interestingly, in the state of Illinois right now, there's a controversy going on in a policy and legal struggle as the state refused to grant nonprofit status or to renew nonprofit status to 3 hospitals there because they felt they were not providing enough community benefit programming. So even in the not-for-profit world, we're struggling with, are we doing enough? In the specific case of the DMC and the Vanguard Health System, every day I believe we are living up to our commitments to the underserved and to the city of Detroit. As a private, nonprofit organization, the DMC assumed the role as the major safety net hospital system in Detroit and in the state of Michigan. That remains unchanged. We embrace and celebrate our critical role in the health of our citizens while addressing the challenges of growing and strengthening our business in an increasingly challenging, perhaps hostile environment in the future. I look forward to your questions and comments. Thank you.
Good afternoon, everybody. Kind of hanging in there? I'll see if I can get us back on time here. Now that I'm almost retired from university life, I was somewhat surprised that I was invited to be a panelist at this important symposium on privatization, a critical national issue and one near and dear to the hearts of all of us who live and work in Southeast Michigan and especially Detroit. After I was contacted by John Zervos, I asked him, why me? He responded that his father, who's sitting up in the back of the room there, Mark Zervos, who was one of my very best medical residents at Wayne State University Detroit Medical Center, suggested me because of my long career in caring for vulnerable populations and people. I ran the outpatient department at the old Receiving Hospital. I was the chief of medicine at Receiving and proud to have established the first hospice for indigent patients before I came over to the medical school. I've practiced medicine and geriatrics in this community for almost 30 years. So here I am. I really don't know much about economics, politics, or law for that matter. I did bring a legal pad, and I'm not using slides, so I figured maybe that would impress some of the lawyers in the audience. You know, most of us docs really don't like to be in situations when we're surrounded by lawyers. It's usually a bad thing. There are pros and cons, of course, being in a panel with distinguished guests to going last. One thing I can do is just sum up and comment on what everybody else said, but I'll go out on a limb and try to bring you a slightly different perspective. Let me start with a few general comments. First of all, vulnerable populations for health care are traditionally poor people, certain minority groups, people who are incarcerated, and people with certain medical conditions. I would argue that all of us are vulnerable populations when it comes to disease. Today you're okay, tomorrow you have a serious problem. Anyone. It's important to look at health and disease that way because it gives us a good perspective on the need for all of us to have the best protection that we can from illness that is frequently random and often chaotic in how it affects people. Well, what do vulnerable populations want from health care, especially poor people? This question gets asked frequently by healthcare leaders and government officials. Well, the answer is simple and best summed up by the comedian Sinbad, who said, quote, "Poor people want the same thing from a healthcare system as you do," end quote. In my words, they want good access to quality, safe care. They want it to be affordable. They want preventive care that is evidence-based. They want a caring and compassionate system of providers. And at the end of life, they want to exit in comfort and dignity. In my opinion, we can achieve all of the above by creating a system with a single payer. And that system would include everyone. And I believe the next best thing to that would be full implementation of the Affordable Care Act. While this position begs the question of privatization versus public ownership versus nonprofit ownership, it gets at the essence of our problem in healthcare in the United States. It would make the issue of for-profit versus nonprofit, in my opinion, less important if everyone had basic and necessary coverage. I'll get down off my soapbox for a minute. It's so hard to get down off your soapbox once you've been a dean of a medical school for a while and address the questions at hand a little bit more directly. I think it's best to look at the healthcare system as a whole. It's complex, very large, and has many individual components. Providers and other healthcare workers, insurance companies, hospitals, pharmaceutical companies, clinics, hospital supply companies, to name some of the major components. And as you can see, many of these components, insurance companies, pharmaceutical companies, hospital supply companies, have always been for-profit, and many traded on the U.S. Stock Exchange. So private for-profit companies are not new to the healthcare scene. And furthermore, many not-for-profit institutions, as Dr. Gray pointed out, like most of our hospitals, exhibit behaviors that look a lot like for-profit institutions. They've been roundly criticized for this, and some changes have occurred over the last decades which regulate how hospitals must act, especially if they're tax exempt. So let's look at a model to get at this notion of profit versus nonprofit in healthcare that's been around for a while. Most hospitals are nonprofit, and this trend for hedge funds like Blackstone and for-profit companies like Vanguard buying them up is relatively new. By the way, for today's purposes, we're going to ignore the question of whether any profit should be made on people's illnesses. That is, there is a major moral question here before us. So an industry that has been around for a while, the health insurance industry, has major for-profit corporations in it, some nonprofits, sort of, and the government programs like Medicare and the VA. If one of our major goals is to deliver quality care at affordable prices, let's compare for-profit insurance versus Medicare. In a nutshell, Medicare does quite well in that comparison. It delivers at lower cost an alternative to private for-profit insurance of comparable quality. It does this by lower administrative costs and no advertising, and it also doesn't have to make a profit. Additionally, because Medicare's goal is to deliver a cost-effective product to everyone over 65, it takes everyone. No cherry picking, as do companies where the bottom line and obligations to stockholders are key. Can we extrapolate any of this to the Vanguard purchase of the DMC? And as people have done with much more depth and knowledge than I have of the situation, however, I think it is important to go over the historical context. The DMC has been the hospital of last resort for decades in Detroit, willing to take on all comers, and especially Children's Hospital in Detroit Receiving. A disproportional burden for indigent care has always been borne by the Detroit Medical Center. DMC management tried to deal with the real issues like outdated equipment and facilities by going to the bond market, and as Dr. Gray has already pointed out, they were rebuffed. It's hard to argue with a major capital infusion for all DMC facilities and money to pay off mounting debts. The DMC Vanguard deal was closely scrutinized by the state of Michigan and organizations like Marge's, and the city has also played a role in seeing that a fair deal for the people of the region was supported. Vanguard, as an organization, seems to have a significant commitment to the underserved, as evidenced by its track record in Texas and other places where it operates. The downside. Vanguard, like all publicly held corporations, owe a primary responsibility to stockholders. Vanguard has a multi-year tax exemption, and what happens when they must begin to pay taxes. Some services naturally make money, like specialty surgery and invasive cardiology. What about caring for patients who have sickle cell anemia, a money loser for many institutions? Do they get dropped eventually by the DMC? And finally, for-profit hospitals cost more to run than nonprofits. And I think even though the article is a little dated, the article that appeared in New England Journal in '97 by Will Handler and Himmelstein did a nice job to show how that sort of plays out. So, moving forward, from my perspective, let's hope the Supreme Court does the right thing. Secondly, we need to push for Obamacare Plus, which in my opinion means a single payer. We need to revamp and realign our healthcare system so providers are incentivized to keep people safe and well. We need to insist in the short run that all hospitals in a region like ours do their fair share of caring for indigent patients. And as a community, we need to watch Vanguard like a hawk and see that they live up to their commitments. Let me just end with a quote from Marcia Angel, who's a former editor of the New England Journal of Medicine. She says, "We live in a country that tolerates enormous disparities in income, material possessions, and social privilege. That may be an inevitable consequence of a free market economy, but those disparities should not extend to denying some of our citizens certain essential services because of their income or social status. One of those services is health care. Others are education, clean water, air, equal justice, and protection from crime, all of which we already acknowledge are public responsibilities. We need to acknowledge the same thing for health care. Providing these essential services to all Americans, regardless of who they are, helps ensure that we remain a cohesive and optimistic country. It says that when it comes to vital needs, we are one community, not 300 million individuals competing with one another. In seeking to ensure adequate health care for all of our citizens, we have an opportunity to reassert that we are indeed a single nation. Thank you.
Well, I want to thank all of our panelists. This was a really interesting discussion. I thank all of you for sharing your viewpoints.